Imagine for a second that you've been managing this highly personal, just incredibly frustrating physical issue for years.
Oh, the kind of thing that makes you hyper aware of every single movement you make.
Exactly. Like you hesitate before you exercise or you brace yourself before you laugh. You're constantly mapping out the nearest restroom just so you can confidently go about your day.
It's exhausting just thinking about it.
It really is. But finally, you take the leap. You undergo a surgical sling placement to correct it.
And the procedure goes flawlessly, of course.
Right. You wake up in recovery, you're thrilled the mechanical issue is fixed, and you're just ready to reclaim your active life.
But then reality hits.
Yeah. You're prepping for discharge, and you're handed this standard packet of post-op instructions. And it mandates that you put your intimate life completely on hold for a month and a half.
It is such a profound, sudden stop. I mean, the physiological problem is fixed, the surgery was a success, but the patient is immediately burdened with this heavy, lifestyle-altering restriction.
That jarring disconnect is exactly what we're dissecting today. Welcome to the Deep Dive. Today, we are scrutinizing the universally accepted recovery timeline for resuming sexual intercourse after surgical sling procedures.
And, we're dealing with an informed audience here, so we all know these procedures, whether they're for male or female patients. They involve placing a supportive sling under the urethra to treat stress urinary incontinence.
Right, millions of these have been performed globally. But to really get to the bottom of this, we pulled a mountain of sources. We're looking at clinical guidelines and post-op care sheets from Mayo Clinic, Brigham and Women's, the NHS.
The heavy hitters, basically.
Exactly. And we're pairing all that standard advice with this groundbreaking new randomized controlled trial. Our mission today is to uncover the standard medical advice, understand, why it actually exists, and explore how new research is completely upending the status quo.
Which is long overdue, frankly.
Totally. Okay, let's unpack this because the global consensus in these clinical brochures is undeniable.
It really reads almost like ancient dogma at this point.
It does. Whether a patient gets a male sling procedure like the Advance or ADAMS systems or, a female mid-urethral sling, the discharge paperwork looks absolutely identical.
Right. It's a minimum of 4 to 6 weeks of total abstinence from sexual intercourse. Often they just call it pelvic rest.
Yeah, pelvic rest, and it's treated as this immutable law of surgical recovery. But I don't want to just accept that rule at face value, right? Like surgeons aren't issuing this mandate just to be puritanical.
No, not at all. There is a very real structural rationale at play here regarding how these slings actually integrate into the body.
So walk us through the biology of that. Why the strict waiting period?
Well, it's entirely based on the mechanics of tissue healing. When a surgeon places a sling, they're often using a synthetic polypropylene mesh or sometimes a strip of autologous fascia, which is tissue harvested from the patient's own abdomen.
Okay, got it.
The critical concept here is that the sling is not permanently bolted or heavily sutured into its final load-bearing position.
Oh, really? I think most people assume it's like carpentry in there.
Right. But no, it acts more like a hammock. And while the surgeon positions it accurately, its long-term tensile strength doesn't actually come from those initial sutures.
It relies on the body's natural response to the material, doesn't it? It's like planting a new sapling in your yard. You have to let the roots take hold in the soil before you subject it to a windstorm, right?
That is a perfect analogy, yeah. The body initiates an inflammatory response. So macrophages arrive at the site, and fibroblasts begin laying down new collagen fibers that weave directly through the pores of the synthetic mesh.
The roots taking hold.
Exactly. It's very similar to pouring concrete over rebar. The mesh is the rebar, providing the scaffolding, but the structure has zero strength until the body's concrete, that collagen, cures and hardens around it.
And historically, the surgical community just assumed this curing process took a full 6 weeks.
Yeah, they assumed you needed that long to achieve enough tensile strength to withstand external mechanical stress. Because if you shake the rebar before the concrete is set,
You compromise the whole foundation.
precisely. In pelvic surgery, the primary fear driving this wait time is the risk of the mesh dislodging, shifting, or ultimately eroding and becoming exposed in the vaginal wall.
Which sounds awful. How often does that actually happen?
It happens in roughly 2 to 4% of cases, and when it does, the clinical consequences are severe. Patients can experience bleeding, abnormal discharge, and really intense pain during intercourse.
And I imagine fixing that isn't easy.
Not at all. It's a highly complex revision surgery. So doctors prescribe this conservative waiting period purely to prevent that specific complication.
Okay, so optimizing for structural integrity makes perfect sense biologically. You want the hammock to stay exactly where it was placed. But it feels like hyper-focusing on that completely sidesteps the psychological and emotional toll this takes on the patient.
Oh, absolutely, because pelvic rest is rarely just a ban on intercourse.
Right. These standard post-operative behavioral restrictions are exhaustive. The 6-week ban on sex is always coupled with these really strict lifting restrictions. They usually cap you at 10 to 20 pounds.
Which is practically nothing in daily life.
Exactly. To put that in perspective for you, that means for a month and a half, you cannot lift a bag of dog food. You can't carry a vacuum cleaner up the stairs. You cannot pick up your toddler.
And no baths, no swimming, no strenuous exercise.
Yeah, no running, no yoga. You are effectively ordered to treat your body as if it's made of glass for 6 straight weeks.
Which brings up this massive healing paradox when you look at the broader landscape of modern surgical recovery.
Right, because if you look at the sources from general surgical recovery, like the Practice Plus group, the consensus is entirely different.
Completely different. They have a deep, well-documented understanding that resuming normal activity, and yes, that includes sexual intimacy, is actually a critical factor in holistic wound healing.
Yeah, the literature explicitly points out that resuming sexual activity boosts endorphin levels,
Mhm.
which, act as natural painkillers.
And it significantly reduces postoperative anxiety.
Right. It restores a patient's bodily confidence and reconnects them with their partner after what is, frankly, a super stressful medical intervention. But wait, if general surgery guidelines say getting back to intimacy is actually good for physical and emotional recovery, why are we keeping urogynecology patients on the bench for a month and a half?
Are doctors just being overly cautious?
Yeah, exactly.
Well, this raises an important question. Is this restriction rooted in hard data, or is it just deeply entrenched institutional tradition?
I have a feeling I know the answer to this one.
You probably do. For a long time, the 6-week rule wasn't based on prospective, randomized clinical data at all. It was born entirely out of tradition.
Wow. Just a guess that became a rule.
Pretty much. Decades ago, early surgical pioneers observed that basic fascial wound healing takes roughly 6 weeks to reach about 80% of its original strength.
Okay, so they just extrapolated that general timeline.
Exactly. They applied it as a blanket restriction to all pelvic floor procedures, regardless of the specific materials being used. It's the classic medical trap of, well, that's how we've always done it.
That is wild. Nobody actually rigorously tested it to see if tissue integration with modern synthetic mesh happens faster than traditional healing?
Nope. Until very recently, the entire medical apparatus was operating on an untested hypothesis.
Well, here's where it gets really interesting. Because a groundbreaking multi-center randomized controlled trial finally challenged this. It was published in the American Journal of Obstetrics and Gynecology.
Yes, spearheaded by Dr. Catherine Matthews and her research team, they realized there was zero data and decided to actually test the validity of the 6-week rule.
And the setup was pretty bold, right?
It was elegantly straightforward, which makes the data so compelling. They specifically focused on sexually active women who were undergoing synthetic retropubic slings.
Okay, and how many women were involved?
They enrolled 124 women across 4 different clinical centers in the U.S. At the 2-week post-operative mark, if the patients were visibly well healed, they randomized them into 2 distinct groups.
Right, so you have this standard group who were told to follow the traditional dogma, complete restriction from intercourse, for the full 6 weeks.
And then the early group, who were explicitly cleared to resume intercourse immediately, just 2 weeks post-surgery.
Which is cutting the recovery timeline by nearly 70%. That's a radical departure from the standard of care.
Oh, it was a huge risk in the eyes of the establishment. The prevailing assumption was that allowing intercourse at 2 weeks would subject the poorly integrated mesh to shear forces, causing a massive spike in mesh exposures.
But let's look at the underlying biology first before we get to the human trial results, because there's some really fascinating animal model data in the sources that suggests we severely underestimated how fast tissue integrates.
Yes, the rabbit model data. This is the biological key to understanding everything. Researchers implanted synthetic mesh in an in vivo rabbit model and then tested the force required to detach it from the surrounding tissue at various times.
Wait, and what did they find?
They discovered that the tissue ingrowth was incredibly rapid. The cellular matrix infiltrated the pores of the mesh so aggressively that the detachment strength was robust enough to hold firm as early as 7 days after implantation.
7 days.
Just
That
saying.
blows my mind. The biological concrete basically cured in a single week. The collagen deposition catalyzed by the synthetic material just happens exponentially faster than anyone thought.
Exactly. Which brings us right back to the findings of the human trial. When these 124 women returned for their 3-month evaluations, the results completely dismantled the traditional narrative.
Okay, give us the numbers. How did the early group do?
Despite decades of dire warnings, the group that resumed intercourse at 2 weeks had exactly 0 cases of mesh exposure.
0. Wow.
0. The singular catastrophic complication that the entire 6-week mandate was designed to prevent it just didn't occur. The structural integrity of the sling held up perfectly.
So it completely validated the rapid tissue integration from the rabbit models. But what about the primary objective of the surgery? Did early intercourse mess up the incontinence cure?
Not in the slightest. Surgical success and satisfaction rates were nearly identical between the two groups. It was 66% for the early group and 68% for the standard group. From a statistical standpoint, there's no meaningful divergence there.
That is incredible. The synthetic sling functioned exactly as intended, whether the patient waited 14 days or 42 days.
However, we do need to analyze one specific nuance in the clinical findings regarding de novo dyspareunia.
Right, the new pain metric.
Yeah.
So for the audience, de novo dyspareunia refers to new onset pain during sexual intercourse that the patient did not experience before the surgery. What did the trial data show there?
At the 3-month follow-up, 17% of the women in the early 2-week group reported new pain during sex, compared to only 7% in the standard 6-week group.
Okay, that feels like a notable difference.
On paper, yes, but the researchers noted that due to the sample size of 124 patients, this specific difference did not meet the threshold for statistical significance. It could potentially just be random chance.
See, I want to challenge that premise for a second, because I feel like in clinical research, we often hide behind the phrase not statistically significant due to sample size. But a 10 percentage point jump in a pain metric is highly relevant to the person experiencing it.
That is a very valid clinical critique.
Right, because if you tell a patient their risk of experiencing new, persistent pain might jump from 7% to 17% if they don't wait an extra month, a lot of patients might voluntarily choose the longer restriction. We shouldn't just dismiss that signal.
I agree completely. Statistical significance and clinical significance are two very different beasts. That 17% is an important signal that warrants cautious interpretation. It suggests that while the structural integrity of the mesh is secure at 2 weeks, the local inflammatory environment might still be sensitized.
Which means it definitely warrants further study.
Absolutely. But the overarching conclusion regarding the mechanical safety of the implant itself, the lack of mesh exposure, remains incredibly robust.
Right, the structural safety is proven. And knowing that the physical outcomes are practically identical, we have to shift the conversation to the patient's actual experience. Because medicine is about restoring quality of life, right?
If we connect this to the bigger picture, the preference data from this trial is perhaps the most illuminating metric we have.
Oh, this is my favorite part of the study. It is so relatable. When the researchers surveyed the women about their assigned recovery timelines at the end of the study, the contrast was staggering.
Tell them the percentages.
Okay. Of the women forced into the traditional 6-week restriction group, 43% explicitly stated they wished they had been in the 2-week group. They felt sidelined for no reason.
Which is totally understandable.
Right. But on the flip side, of the women in the 2-week group, only 13% felt they would have preferred a longer restriction.
It is a definitive demonstration of patient preference. When you remove a restriction that offers no real biomechanical benefit, patient satisfaction skyrockets. And frankly, urogynecology is simply catching up to a massive paradigm shift happening everywhere in medicine right now.
Yeah, we're seeing this trend with ERAS, enhanced recovery after surgery protocols. It's happening across virtually every discipline.
Exactly. Look at major orthopedic procedures like total knee replacements or complex hernia repairs. For decades, the standard was strict, prolonged bed rest.
Which we now know is terrible for you.
Right. Today, orthopedic surgeons have joint replacement patients standing and walking on the very same day as their operation.
Because early mobilization stimulates blood flow, it reduces the risk of blood clots, and it prevents muscle atrophy. The old model of wrapping patients in bubble wrap for 6 weeks is just being systematically dismantled by actual data.
We have to stop treating patients as if their existence is paused the moment the anesthesia wears off. It's moving away from a paternalistic model of care toward evidence-based patient empowerment.
So what does this all mean for you, the listener? Synthesizing all of this, patient-centered care means we have to recognize the collateral damage of these long restrictions. Like, if your profession requires lifting more than 10 pounds, say you're a nurse, or you work in a warehouse, or you're a childcare provider.
A 6-week restriction means you are economically sidelined for a month and a half. That is a devastating loss of income for a lot of families.
Exactly. If the evidence proves we can safely return people's autonomy, their intimacy, and their livelihoods in just 14 days, the medical establishment has an ethical obligation to update the playbook.
And this study provides the precise empirical evidence needed to update those outdated discharge packets.
It really does. So just to wrap up the deep dive today, we started with this rigidly accepted 4 to 6 week recovery playbook, a rule so baked into the culture it was on every hospital's discharge paperwork. But by looking at the tissue biomechanics in this cutting-edge trial, we've seen the dogma defeated. The data proves that a 2-week timeline is structurally safe, highly preferred by patients, and maintains perfect surgical efficacy.
It is a huge leap forward. But, and this is a crucial clinical caveat, patients must always consult their specific surgeon.
Right, absolutely.
The aggregate data is promising, but healing is individualized. This trial looked at synthetic retropubic slings. Factors like whether your surgeon used synthetic mesh or autologous tissue matter greatly. Your surgeon's clinical judgment is always the final authority on your specific recovery timeline.
Yeah, that personalized consultation is non-negotiable. But looking at the broader implications, I want to leave you with a final, slightly provocative thought to ponder. If a widely accepted, aggressively enforced 6-week medical restriction was safely slashed down to just 2 weeks, simply because someone finally decided to test it, what other strict post-operative rules in medicine are we blindly following just because that's how it's always been done?
It makes you wonder.
It really does. Could other agonizing, economically devastating surgical recoveries be dramatically shortened if we just dared to question the status quo? Something to keep in mind the next time you're handed a list of absolute medical rules.